I'm Dr. Sabrina Siegel with the Neuroscience Education Institute. Welcome to the NEI podcast. On this show, I sit down with renowned mental health care experts from a range of diverse backgrounds to discuss breakthroughs and best practices for treating patients with mental health conditions. We are at the 2021 NEI Congress, and I have here with me today Dr. Manpreet Singh. She just finished her amazing talk called It's a Woman's World, and we are talking about all things that have to do with female mental health today. And today we're going to get a chance to have some of your unanswered questions that we didn't have time for her to address while she was on stage. You are going to have a chance to get those answered today. So welcome, Dr. Singh.
Happy to be here, Sabrina. Thank you.
My first question for you is, for PMDD, what are some factors that influence the decision to prescribe luteal phase SSRI dosing versus continuous dosing? What can you share with us about that?
Sabrina, I'm so glad you asked this question. It really reflects the knowledge base of the audience and the fact that they're very sensitive to one major take-home point from my talk, which was that it matters to think and understand the reproductive hormone cycle and to be able to appreciate how that might impact your treatment recommendations. So the approach that I take when I see a woman who has PMDD, who might be, lifestyle-wise considering intermittent dosing, I'd want to talk to her first about her comfort level with that. The reason is because when you do intermittent dosing of any antidepressant, there are some issues to work out. And that relates to the fact that you can get some side effects and challenges with dosing and efficacy when you do that kind of intermittent approach. And in fact, people who do opt for luteal phase specifically treatment are probably ones who know themselves and their bodies very well. So the first question I'd ask is, have we established that this is truly a luteal phase PMDD? Like without a shadow of a doubt, tracking across at least 2 cycles, if not more, is the patient convinced that the PMDD symptoms only arise during the luteal phase? And if that's the case, the suggested approach that I've seen and heard work well for those kinds of patients is you start at probably half the suggested effective dose of an SSRI and do continuous treatment first. And the recommendation is to do that for at least 6 months before the body is acclimated to be able to tolerate the maximum effective dose. So what that means is that a patient might say, hey, I want to try this intermittent dosing. Let's try a trial, make sure your body is acclimated to it, you're not having any side effects, and that you're truly benefiting optimally from the maximum effective dose. And then we can move to a more intermittent cycle. And what that does is just mitigates all of the side effects that can happen with start-stopping.
Gotcha.
Does that make sense?
Yeah, absolutely. Thank you. That was so interesting. Our next question is, can fluctuations in hormone levels during perimenopause contribute to behaviors that might mimic hypomania?
That is another great question. And perhaps one might worry that mania is really the issue. But if someone hasn't ever had manic symptoms before, then the best approach would be to first start by describing the behaviors, and that uncertainty can then lend itself to more further investigation. So what I mean by that is, what is the mood? What is the index mood that the woman is experiencing? That at the time of that perimenopausal period, it might strike a chord with a potential bipolar diagnosis. Is it euphoria or elevated mood or explosive irritability? Once that mood is established, then you go ahead and look for secondary symptoms and look for an episode. So mania, diagnosis of bipolar 1 disorder, would require that you have at least a week of sustained periods where more days than not you have an elevated mood or euphoric mood or explosive irritability at least 50% of the day or more every single day for at least a week. And it's accompanied by other symptoms: distractibility, increased goal-directed activity, grandiosity, flight of idea, finding yourself in a situation where you're talking super fast and can't be interrupted, finding yourself in a situation where your sleep is decreased to the point where you don't need as much sleep. And I did describe during my presentation that insomnia can be a major symptom of menopause. So that's an overlapping symptom to consider. But, insomnia is very different from a decreased need for sleep. The women in the context of a manic episode would need to have insomnia to the level where the next day she doesn't need to catch up. She's not tired. So that subtle difference might distinguish a manic episode from a perimenopausal like insomnia.
Wow.
So that's very important to pay attention to. And then all of the trouble that comes with a manic episode, like sex, drugs, and rock and roll. And so you can't really miss a manic episode because it's such a dramatic shift from functioning. So it's very important for us to contextualize that compared to what might be observed in a perimenopausal phase. So, regardless of what you're doing, if you're wondering about bipolar disorder, you have to find that manic episode and describe it both from the perspective of what symptoms they have and how long they last.
That's excellent. Thank you so much for sharing that with us. The next question is, do you feel that adjunctive treatment of L-methylfolate with an antidepressant in females who have high BMI with MDD tends to work better compared to males with high BMI and MDD?
This person who asked this question really has the literature down. In fact, there's a wonderful paper in Journal of Clinical Psychiatry in 2015 by Shelton et al. That suggests that indeed adjunctive L-methylfolate can be helpful compared to placebo to treat individuals with depression. The thing that I couldn't find in this paper was whether there was a gender analysis, but I can tell you for sure that across all participants and the kinds of people that were enrolled in this randomized controlled trial were adults with DSM-4, major depressive disorder, and an inadequate response to an SSRI. So they were eligible if they had depression and had a partial or inadequate response to an SSRI. Then they were randomized sequentially in a parallel to either placebo or placebo plus methylfolate. And you could see that in the analysis of this randomized controlled trial that the individuals that were randomized to L-methylfolate adjunctively to the SSRI actually benefited more than those that were randomized to placebo. Now, again, whether this is a male or female difference is something that I'd have to look into more deeply in that paper. But Shelton et al., J. Clin Psych, 2015, take a look. I'm skeptical that a gender analysis has been done, only because we tend not to want to slice up the pie with a sample size that may or may not be able to sustain that sub-analysis. But nevertheless, it is an excellent question to see if there might be a differential benefit to women. In this analysis, as I've described it, it suggests that it's true for both males and females.
Wow, so interesting. And we can go ahead and post the link to that publication in the show notes for anyone who's interested. Okay, so our next question is, are you aware of any role for the use of pregnenolone neurosteroids in the management of PMDD?
Right, great question. And, I looked to see briefly before we started chatting, Sabrina, that pregnenolone has actually been evaluated using a randomized controlled trial in bipolar depression, but I don't see any papers that have evaluated its efficacy in PMDD. And that paper suggested that pregnenolone was well tolerated. So it's a great thought to consider pregnenolone in PMDD as well. I bet someone in the audience might be inspired to conduct that randomized controlled trial.
Okay, our next question is, can you speak to PCOS in women with this condition who are difficult to treat for mood dysregulation and anxiety?
Yeah, it's a great question. Again, one of the things that we didn't cover in this presentation was polycystic ovarian syndrome, or PCOS,
Right.
another very important condition that affects females. And would you believe it, Sabrina? Over 30% of women with PCOS have depression, compared to 7% of the general population, and 45% of them have anxiety, compared to 18% of the general population. So this comorbidity is real and does merit consideration in terms of treatment planning. And I suppose in the absence of other data, I couldn't find anything that specifically addressed the treatment of PCOS related mood symptoms. But my instinct would be to first try treating the PCOS as a primary disorder, to see if the mood and anxiety symptoms don't go away. And if they don't, in that instance, then institute some of the tried and true strategies to treat depression and anxiety, including SSRIs and SNRIs, taking, of course, a personalized approach. So I don't think that it's a bad idea to be thoughtful about treatment of PCOS-related mood and anxiety conditions. I am not aware of systematic studies that have evaluated that.
Okay, thank you so much for sharing that with us. The next question is, if someone has both MDD and PMDD and is on SSRI therapy, is there any benefit in increasing the dose for part of the month to target the PMDD symptoms? Very interesting.
It is a very interesting question. And in principle, I would think that this approach could be very useful. And just like we started off our conversation about considerations for luteal phase dosing, this question sort of gets to another suggestion that, where you're honing in some ways to the symptoms that are exacerbating a primary depression because of the hormonal interactions and because of the reproductive cycle. So in principle, I think that the dose adjustment during those periods when the PMDD symptoms are most problematic could work similarly to that luteal phase strategy, where you might consider intermittent dosing. And in fact, I would think that a relative increase in dosing during the PMDD symptoms would actually be better tolerated than starting and stopping at every cycle, as the intermittent dosing strategy suggests. So I think this is a very interesting question. And in principle, I think that it could be a very useful approach.
Thank you. The next question, it asks, it's sort of related, but it asks, how often is anxiety present with perinatal depression?
Very helpful to distinguish whether comorbid anxiety is a comorbidity or a premenstrual exacerbation of an underlying axis 1 disorder. And the way you have to do that is to really look at all of the symptoms and try to understand the time course of them.
Right.
Common things come, and these things often run together. And so that's why the charting of the cycles across several cycles can give you the data that you need to be able to make those determinations, those diagnostic determinations. And it's actually true that anxiety as a comorbidity with perinatal depression is likely to be higher. And the treatment of anxiety during that time would require a sensitivity to understanding, again, whether it's a primary anxiety disorder or an exacerbation of a hormonal.
Wow. Thank you. That's great distinction. And I like that we are discussing the comorbidities. I think it can be very challenging to try to parse these apart. The next question is, if one decides to treat PMDD with drospirenone ethinyl estradiol, is there risk to precipitate depression or suicide? And if so, is the risk very low?
This is a great question. The relative risk for a first suicide attempt by type of hormonal contraceptive currently used is actually available in another article that I'd love for you to post for our audience, because it's not actually very low. It turns out that oral contraceptives like drospirenone, ethanol, estradiol does have an associated risk, a hazard ratio of 2.05. And the risk seems to be higher for adolescents with this condition compared to older females. So we'll share that article as well so that you can kind of get a sense of how this association plays out. And I'm wondering at some point if a black box warning, if it isn't there already, might be indicated for hormonal contraception in the context of treating mood disorders.
Absolutely. Should be interesting. Our next question is, due to high bipolar incident in PPD, is there a risk for brexanolone to increase mania?
You know, Sabrina, I'm not aware of any of the trials of brexanolone reporting adverse events that are reminiscent of mania-like behaviors. That being said, I could totally be wrong about that. I don't see any contraindications of brexanolone that are immediate or obvious to me that would suggest that we would want to avoid it. And I understand the question because, say, for example, you haven't made a diagnosis of bipolar disorder, you haven't recognized it. Through no fault of your own, are you inadvertently putting a person at risk for inducing mania? And as I said, to my knowledge, I'm not aware of it. I do know that other steroids have had risk factors like induction of mania, and case reports have described this phenomenon. But I have not seen that in the brexanolone literature to date.
Okay, thank you so much. And that takes us to our final question, which is esketamine an option for severe postpartum depression? What are your thoughts on that?
You know, esketamine is indicated for MDSI or major depression with suicidal ideation. In the context of postpartum depression, if a woman has severe depression with suicidal ideation, one could imagine that for very severe cases, esketamine potentially could be useful. The data will still be emerging for that particular indication and specifically for that indication. But again, I would want to make sure before I did go down that path that I have a very clear understanding of any potential risk factors for postpartum depression, especially for a lactating woman. And so even though, we know the relative safety of SSRIs for lactation, the literature is likely less clear about agents like esketamine. And so before I would consider esketamine, I'd probably really want to be sure that the risk-benefit ratio is favorable and certainly, again, use in a very specific indications as esketamine has been labeled to be used. There is a clinical trial registered for low-dose esketamine in women with prenatal depression, which is going to help us maybe understand better the value and utility of this particular agent for women. And I'm glad to see that on clinicaltrials.gov. So the jury is out and stay tuned for more.
Wow, that's great. Well, thank you so much, Dr. Singh, for joining us today. And thank you for addressing so many of these great questions. Thank you so much.
My pleasure, Sabrina. It was great talking to you. And thank you to the audience for such terrific questions.
Thank you so much for joining us for another episode of the NEI podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today.